Thank you. Thank you all very much for allowing me to be here and talk about something that is not a part of your field of expertise, and that's lasers. I think that there's a very big place for lasers in treating all of your patients with bleeding disorders. Today we'll talk about three different parts of this whole puzzle. One is surgical intervention, selective photocoagulation, and the part that relates directly to Lochna's wonderful study and fantastic results, and that's photobiomodulation. She has called it low-level laser therapy, LLLT. That is just another name for PBM, or photobiomodulation. I know that you probably only have a passing knowledge of lasers, so I want to spend just a couple of minutes trying to get you at least on a basic level of understanding. In dentistry today, lasers are not a new technology. They've been around since the 60s. They're not new to dentistry. They've been around since the 70s. But they really have not been applied in the field of your expertise, and I think that's a mistake. Right now, with the major groups of lasers that are available are the diode, the Nd:YAG, the erbium family, and carbon dioxide lasers. All of these can be used on soft tissue. Only the erbium laser is appropriate for doing hard tissue, for enamel, dentin, and bone. Today, because we have such a short period of time, we're going to talk exclusively about the diode laser. This is something that everyone in the laser field understands, but something that looks rather complicated, but I put it in here because it makes a very important point. Here is the diode, the Nd:YAG, the erbium, the CO2, and this scale is different wavelengths of energy. You can see by these curves that the interaction with tissue components is highly dependent on the wavelength, and as a matter of fact, this is a logarithmic scale. So this means it interacts 10 times 100, 1,000, 10,000, 100,000. So erbium energy is absorbed in water more than 100,000 times as much as diode laser. The major tissue chromophores, and tissue, particularly mucosa, is made up of about 90% water, 10% proteins. If you look, you see that with the diode, there is almost no absorption at all in the major component, which is water. I will oversimplify this a little bit and talk about oral mucosa. We have epithelium that's perhaps 100 to 500 microns in thickness. The entire mucosa may be 1 to 3 or 4 millimeters thick, depending on where it is in the mouth and what its function is. Diode laser energy penetrates about 4 millimeters into the tissue. It does that because while there is some protein here, this is mostly water, and it's not absorbed in the water at all. Nd:YAG is the same, penetrates greatly. But remember, I said that the erbium is absorbed 100,000 times as much. It only penetrates 1 micron into the tissue. If I shine a diode laser on the tissue here, it goes in 4 millimeters. If I pick up the erbium laser, 1 micron. It is very superficial. The same thing applies with the CO2. You should be able to immediately say, aha, I see a very, very clear divide here. There are two on the left, the diode and the Nd:YAG, that are appropriate to have energy penetrate down to where all the lymphatics and all the blood vessels actually live. On the right, These do not at all. They will never get there. When you begin to look at this, you say, if my job is to treat hemophilia, that's blood, that's way down here, this is what I need to be using. There are some applications for the Nd:Ag, but again, only the diode we're going to talk about today. So the question becomes, which one of them is best? These are 4 fibromas. That one was removed with a diode, that with an Nd:Ag, an erbium-YAG, and a CO2. Obviously, they all did a decent job of removing it, and if you were to look here, you would say, all right, if I asked you which is the one that was best, you might immediately look at the erbium-YAG and say, wow, that is nice and clean, there's no carbonization, the tissue looks healthy. That's all true. That's because the energy only penetrates a micron or so. There's almost no collateral damage. The problem is, for your patients, you get almost zero coagulation with the erbium. For me, for my normal patient, I every day decide, do I use the diode or do I use the erbium-YAG, and it depends on the particular procedure. But for your patients, you would never use the erbium. Never. It would be like a scalpel. When you cut that tissue, bleeds immediately. This has been cleaned up very nicely, but that's not what you see in the mouth. Diode becomes what you need. The question is, what happens later? How do they heal? This is 3 weeks later. With the diode, you see a little scar tissue here. That's probably because they used a little too much energy. But basically, all of them healed completely uneventful. So they can all be used on soft tissue, but not on your patients. Never use an erbium. So, that's as short as I could make a many-hour lecture on lasers. I'm sorry. I'm sorry. I know it wasn't too clear, but it is what it is. You learn the one lesson. Use a diode, and I'm going to show you in just a second exactly why. Let's talk about the first thing, which is surgical intervention, what I just showed you. When you use a diode, remember, it is not absorbed in water, and it's absorbed some in hemoglobin and proteins. But if you want to do a surgical procedure, if you want to remove a fibroma, you need to have energy that's being absorbed in the superficial tissue for surgery. You do that by a technique called initiation, where you put some pigment on the end of the diode fiber. Here's a close-up of my fiber that is 400 microns in diameter. So right on the end of it, to the left, right there is about 200 microns thick and 400 micron wide area of pigment. That pigment, here comes the laser energy down this glass fiber, and all of it is absorbed right there. This tip right here gets very hot. None of this does. This is what separates it from an electrocautery, where everything is hot and you get tremendous amount of collateral damage. Here, you do not. So you can do surgery like this very simply, very benignly with a diode laser. You say, okay, that's nice to know, but what about for my patients? Here is something that you would have a lot of trouble doing on any of yours. This is a free gingival graft that I've done. Anybody who has done those knows that the hardest part is dealing, in a regular patient, dealing with the bleeding. I take a graft, set it in place there, and it floats away before I can suture it down because of the bleeding. Imagine you're a hemophiliac patient. This would just be impossible. But what if you could do this exact same thing like this. I did this with the diode laser. You have that highly concentrated little blob of thermal energy where the pigment is attracting it. This is absorbed, it heats up the proteins and separates them. But it also does the most important thing. Blood vessels less than a half a millimeter in diameter are instantly automatically sealed. Here's a blood vessel, and this is from, photothermal coagulation of a blood vessel. You can see this is a reasonable-sized vessel. Right here, they applied diode laser energy. Instantly, you get contraction. All of the collagen fibrils that go around, it's a triple helix. As you heat it, when you get it up to somewhere around 60 to 65 degrees, they begin to contract. So they take this blood vessel and just make the lumen smaller, and that's what you see here. So how does that work here? If I transect this right here with the diode by melting the proteins here, I leave on both sides a very small lumen with a little coagulated protein in it, sealing it off. No bleeding. This has absolutely nothing to do with clotting factors, with platelets. This is very simply a thermal interaction that has closed off the end of this blood vessel. This happens instantly up to about a half a millimeter diameter vessel. I read a recent study where by using a clamp, they can take a 6 millimeter diameter vessel. That's pretty darn big. Clamp it down, run a diode laser across it, have it sealed so it withstands a pressure of over 500 millimeters of mercury. That means that this is sealed way beyond anything my heart may get up there, but what normally is not done. This has a real advantage for your patients. This isn't new. This is a study from 1985, laser surgery and hemophilia. Some adventuresome soul in 85 did this, and somehow in the last 30 years, no one has picked it up. And I'm here to tell you, I think this is something that we need to do. This is a case that I did, cosmetic recontouring of the gingiva. And as you watch, you can see, anybody who's done these knows how much bleeding you get. And you say, well, this is really healthy tissue. It wouldn't bleed very much. I'll admit to that, but watch something here. This is a case where now I have separated that tissue. You see how easy that was? But now if I go in with the curette and pull a little tag off interproximally, all of a sudden it starts bleeding. It's as simple as that. You see on the contralateral side where I had worked before, there's plenty of bleeding there. But using this technique, look how I can sculpt the tissue. There's no way that I can, with a scalpel, make that tissue look that beautifully contoured. On the top, you see the before and the after. And actually, if you see this white line here, this white line here, that's where the tissue was. See that? So I've taken off that much tissue. Any place where I use the laser, here, no bleeding. Any place I used a curette interproximally to remove some tissue tags, bleeding, 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 bleeding. If I had known that I did this years ago, but if I had known what we're talking about right now, I could have used the diode to remove those tags, and I bet I could have done this whole procedure with barely a drop of blood, period. This, again, has great value, I believe, for your patients who have bleeding problems. When you consider, you take exactly the same procedure. Here I did it my conventional way, here with the laser. When you start thinking what this difference could do for a patient with a bleeding disorder, I think it's pretty mind-boggling. And again, nothing to do with platelets, nothing to do with clotting factors. This can be done on your patient just as well as it's done on a patient with normal blood clotting. Now we're going to talk about another thing, selective photocoagulation. This is doing kind of what I just talked about, but doing it through intact tissue. What would you do? What would you do if this patient came in to see you and had hemophilia? With a hemangioma like this, this is a lose-lose situation. If you say, I'm not going to do anything because of this bleeding disorder, and that patient bites down on that, which is how he got it in the first place. So it's going to happen. It's a matter of when. If he bites down on that and ruptures that, he is in big trouble. If you go in and say, I'm going to carefully dissect this, go in, ligate both sides of this, and cut this out, you're putting yourself in trouble. You have to have this patient on replacement and probably hospitalized just to take that out. Now watch this. This still absolutely stuns me every time I see it. This is developed by my good friend Rolando Crippa. There it is. He's from Milan. He's a maxillofacial surgeon. Diode laser. Just look at this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 seconds, you're done. Look at that, it's gone. In 10 seconds, he's going to go back and touch up a couple of little spots. What has happened here? Just what I told you, that these blood vessels, these small blood vessels shrink, the lumen closes, no more blood coming in to there. Some of the proteins in there are coagulated. That's it. 5 seconds, 10 seconds of treatment, and you have done something that you couldn't possibly do any other way. Here it is about a month later. That's just amazing. It happens because the diode energy is poorly absorbed in water, so it penetrates all the way down to where the blood vessels are. It's highly absorbed in the hemoglobin, so then it's absorbed by the hemoglobin, heats up the cells, causes the collagen to be denatured, to shrink, and close the lumen, and that's it. Rolando Crippa from Milan. Fantastic. Now we're going to talk about what Lochna has shown you before, photobiomodulation, low-level laser therapy. It is a process where light is absorbed by the cellular components. What happens? The cellular metabolism is enhanced through activation of cellular respiratory chain. Okay, what does that mean? Mitochondria absorb the energy and they use it to increase the metabolism of each one of those cells. ATP production is enhanced. Cytochrome C oxidase is stimulated. Increased macrophage activity, so you start eating up all this dead tissue a lot faster. Increased keratinocyte activity, so you start developing new tissue faster. Every one of these is an awful good thing. So on the cellular level, yes, as I just said, increases cellular metabolism. It also increases migration of cells to cover a wound. The proliferation of new cells through the keratinocyte enhancement, all of that. Increase in synthesis of proteins, significant increase in fibroblast growth factor. All good. Look what that's going to do for you. If you're hoping to improve the healing, everything I've shown you here is going to make a difference. Here is an interesting study of about 10,000 genes. Only about 110 were found to be affected by light, but look at them. All antioxidant-related genes were upregulated. All genes related to energy and metabolism, the respiratory chain, upregulated. Most of the genes related to cell proliferation were upregulated, and some relating to apoptosis and stress response. And remember the word stress response, because we're going to get to that again in a minute. All of those were upregulated. Are there optimal parameters? Yes, let me get to here. The energy level, this is what has been accepted after more than 1,500 papers in medicine and in dentistry. The energy level at the cellular level is the key determinant, and that should be between 3 and 10 joules per centimeter squared. Different people around the world have come up with different numbers, but that is because at the tissue surface, the amount that you apply to the surface of the tissue is not what gets to that cell that's 4 or 5 millimeters deep in the tissue. And the reason I include this is because this is exactly what Lochna is doing. She's applying somewhere in this level in order to get this level down at the cells. This is all explained by what's called the Arndt-Schultz law, which says that if you're below 3 joules per centimeter squared, you have insufficient stimulation of the cells to do all the things, to increase the mitochondrial energy level, all of those things that we talked about. In this 3 to 10 joules per centimeter squared, the energy goes in, it's used by the cell very efficiently. When you get above that level, you have put so much energy in, you have stimulated the cells so much that you begin to deplete all of the energy stores within the cell, and they become less and less efficient and actually become dormant. The energy density and the power density both matter. We don't have time to go into what that means, but what it means is the cellular dose should be 3 to 10 joules per centimeter squared, but it matters how quickly you put that in. You put in 100 milliwatts per centimeter squared. Again, these numbers mean very little to you, but what it says is if I put that energy in over an extended period of time, I can appropriately stimulate the cell. If I put in too much in a short period of time, I start to negatively impact the cell. This has been, as I said, 1,500 papers. That's where we come to. So that's what we're talking about right here. This is a study I've done. Here is a energy dispensing diode laser. The energy comes into the tissue. Here's the surface, and as you go deeper and deeper into the tissue, you start with 50 joules per centimeter squared, and that's too much. You get inhibition here on the surface, but this entire yellow area around here is the sweet spot. That's all between 3 and 10 joules per centimeter squared, and that tissue is going to be optimally stimulated. All the rest of this out here is not, there's not enough energy to affect it. So you're affecting an area that might be 15 millimeters wide and 7 or 8 millimeters deep with the diode laser using the appropriate parameters. So what does this mean for your patients? We go back to all of the things I talked about: sealing of the vessels, going through intact tissue and causing photocoagulation, enhancing the healing, reduced inflammation. If used properly, really no downside to it. This is a study by a good friend of mine, Klaus Neckel from Germany. He is a maxillofacial surgeon in his private practice. 123 patients with various blood dyscrasias. No coagulating agents and no tissue adhesive were used at all. He did 154 extractions, 5 apicoectomies, 16 tumor excisions, did them all, no factor replacement, no tissue adhesives. The post-op outcome and complications were virtually the same as having used those things that you're so familiar with. It has high predictability, high success rate without the side effects, and without the huge, huge cost and without the huge, huge inconvenience to your patients. This is one of the problems we have is there is so little research in this area. Lochner has dug, I have dug, we've looked through, I went all the way back and found that one from 1985 because there's almost nothing more recent. But here's the one good study that has been done. Hemophilia B, a mouse genetically created. You create a 3-millimeter punch biopsy in their back and then see how long it takes for that to heal. Using the laser, did 3 treatments a day, 12 joules per centimeter squared. So that's right near the 3 to 10 that I was talking about at a rate of 125 milliwatts. That's right near the 100 that I was talking about. So this was an appropriately done study. Now, if you take a wild mouse, no hemophilia, no laser, you just poke a 3-millimeter hole in them and see how long it heals, it's going to take 9 days. If you take that mouse and genetically engineer them to have hemophilia but don't use a laser, it takes about 13 days for that to happen. So you have delayed healing by almost 50%. If you take that mouse with hemophilia and then apply the laser, as I showed up here, it only takes 10 days for it to heal. What that says is by simply using photobiomodulation with the laser, you have taken a mouse who has hemophilia and make him heal almost the same as a normal mouse with no hemophilia. I think that's darn good. This is an excellent study, but there are so few of them around. It does all of the things that we've talked about with increasing the healing. But we look at this, so Lochner says, are we talking about the tissue? Are we talking about the blood? Are we talking about the platelets? Where are we having our effect with this? If this is your patient and you stick a periabdominal probe in here, will this bleed? Absolutely. It doesn't matter if they have hemophilia or not. With hemophilia, they won't stop bleeding, but they're all going to bleed because that's what gingivitis is. This tissue is broken down with inside here, and anything you do will cause bleeding. If you used Lochner's protocol on this tissue and then go in and clean, you will have started a healing process here already. You have made this tissue much less friable. You will have less bleeding. That's part number 1 of what she's doing. Here's something that has just started. This is from 2014 by one of the best medical research groups in the world at Harvard Medical School. They're now talking about something called preconditioning. Let me see if I can get this to you. And this is being done in cardiac surgery. What they're doing is saying, if before I take them into surgery, I give them a small challenge, and they do that by creating minor ischemia or some hyperthermia or hypothermia, that they will activate protective responses within the tissue that will make a difference. They will lower the response. They then, the same group, then took a laser and used the laser to do just what Lochner is doing. Before you even start your treatment, you use the laser, you have perhaps preconditioned this tissue to react less, to have its own defense systems up and active when you do your actual surgical procedure. And what I'm trying to do here is answer what her question and my question is. What's behind all this? She has gotten some spectacular results, but we're trying to find out what the mechanisms are. Okay. Here's one. This long name here is another organization like the WHF. They are an international cancer organization from 150 countries. They have a study group whose only job is to minimize oral mucositis during cancer therapy. They have reviewed 24 studies, very valid ones, all double-blind, and they have been able to come up with a recommendation that you can use LLT, PBM, whatever you call it, to prevent mucositis in patients with chemotherapy for stem cell transplantation. Also, in those receiving head and neck radiation therapy. So, chemotherapy and radiation therapy, by preconditioning, by doing just what Lochner is doing, they have found enough evidence for the greatest cancer group in the world to say, I believe that this should be part of how you prepare before you even start the chemotherapy or the radiation therapy. Platelets, harder story to answer. Here's a study that looks pretty good. In vitro PRP, platelet aggregation intensity increased by 15%. The disaggregation time, how long it takes for this aggregation to go away, was increased by 30%. That all sounds pretty good. The Russians have been doing this for almost 20 years. They do it transdermally. They have taken blood, drawn blood, irradiate it, put it back in. They have put laser catheters in and irradiate the blood as it just is flying by, and they've done just about everything, but it's all written in Russian. None of it has been published in international journals. It's impossible to find. We've tracked down little pieces of it. They seem to think that they have a good effect on the platelets. But look at this study. Here's another one that I found, and it says exactly the opposite. Decreases platelet aggregation by 30%. But it says one thing. It said the effect that the laser had can still be noticed an hour later. So that answers, here we'll go by here. This is what's the optimal dose? 3 to 10 joules per centimeter squared. But is the effect long-term, or is it just when you do it? Lochner, and here I'll bring up, there. How many sessions do you need? These are all unanswered questions. That one study seems to suggest that there is a latency, that it actually has a long-term effect on the blood. The preconditioning study says that they can, for the cardiologist, can do ischemia over here on some blood that they can get to, and that it improves the heart's response. What does that say? That says that it's not an effect on the tissue itself, it's an effect on the blood, on the lymph, on the hormones, on something that is circulating through the system. Obviously, these are all early answers to questions. What Lochner has done is open a whole new field of study. This is just fantastic. I think, and there's no magic to this. This is all science. You take a clinical study, and then you sit down and try and create some very carefully designed studies to find mechanisms behind it. That's where we are. We were out to dinner last night and talked about the fact that the problem here is that to get funding from manufacturers for something like this is almost impossible, because your patients are such a small percentage of the world, they don't see the advantage in that. All of this research is crippled by that kind of approach. The only way this happens is to go through grants through educational systems or through large governmental systems.